Dr. Shreyas will be presenting on multimodal imaging characteristics and treatment outcome of retinal capillary microorganisms. Over to you, Dr. Shreyas.
Good afternoon, everyone. I'll be presenting a study on multimodal imaging characteristics and treatment outcomes of retinal capillary macroaneurysms. So, as we all know, microaneurysms have a size of less than 125 microns. They have a capillary origin. They occur usually in clusters and are associated with retinal vascular diseases like diabetic retinopathy and vascular occlusions. In the same lines, retinal capillary macroaneurysms, also known as RCMs, have a size of more than 125 microns. They also have capillary origin. They are usually solitary, and they may or may not be associated with retinal vascular diseases. So, based on this background, we have the objective of this study is to assess the imaging characteristics and treatment outcomes of RCMs. It was a retrospective case series. So, even though we routinely screen our patients for diabetes and we usually see for these aneurysms in chronic conditions, we included patients in whom a diagnosis of RCM was made only after careful examination aided by OCT and fundus fluorescein angiography. Exclusion criteria included conditions which are known to be associated with larger aneurysms. So, by definition, RCMs were defined as orange red retinal lesions with the oval structure on OCT with size greater than 125 microns with no direct communication to retinal arteries or veins. So, we collected the clinical profile of our patients. Fundus photo was documented. Fundus fluorescein angiography was done to know their angiographic characteristics and associated retinal vascular pathologies. OCT macular cube and OCT 20-line raster was done to know the characteristic features of the RCM lesions, and response to various treatments were noted. Coming on to the results, even though we routinely screened our patients, we could only identify 7 patients which had typical RCMs. So, we included 8 eyes of 7 patients, 6 were males and 1 was female. Mean age was 62 years. Best corrected visual acuity was in the range of 6/6 to 6/60 depending on the involvement of macula. 6 patients had diabetes, 2 patients had hypertension and 1 patient had CKD. So, these were the fundus characteristics of the patients. So, to summarize, lesions were solitary in 75% of the patients and multiple in 2 of them. Most of the lesions were located in the posterior pole. It was exudative in almost 75% of the patients. They had an orange-red lesion in all of the patients and associated with retinal hemorrhages in 5 of the patients, visible retinal thickening in 3 of them, and associated exudate rings or clusters in 6 of the patients. So, associated retinal vascular pathologies, almost 75% of the patients had diabetic retinopathy association. 1 patient did not have any retinal vascular disease and 1 patient had BRVO. So, these were some of the fundus pictures of our patients. 1 patient had a perifoveal RCM. The other patient had a RCM along the papillomacular bundle. So, the last pictures you can see multiple RCM lesions. So, coming on to the OCT characteristics, all the lesions had a oval structure. Average size of the RCMs was around 314 microns. They extended from RNFL to outer layers. They had a hyperreflective wall with non-homogeneous variably reflective contents, as you can see in the picture. Surrounding retina showed presence of cysts, schisis, NSDs, hyperreflective dots and hard X-rays. RCM as a cause of macular edema in our patients was attributable in 3 out of the 8 eyes. So, these are some of the OCT pictures of the RCM lesions. So, coming on to the fundus fluorescein angiography characteristics. So, we had hyperfluorescent lesions with minimal leak in almost 75% of the patients. 1 patient, as you can see in the second picture, had a hypofluorescent lesion with no leak. So, hyperfluorescent lesion with no leak was seen in 1 patient. So, this patient had a hyperfluorescent lesion with no leak. So, coming on to the treatment, in one of the patients we gave anti-VEGF which showed very poor response and hence focal laser was considered. In another patient, direct focal laser was considered. In third patient, we gave IVTA. It showed only decrease in macular edema but no change in size of the lesion, where again we opted for focal laser and there was complete regression. In many of our patients, observation was also a treatment strategy. Slide is not moving. हैंग हो गया.
So what's your take-home message with your presentation?
So just one slide is there. In that time, want to conclude that.
Yeah, that's what. Without slide, we can go ahead. Otherwise,
Okay.
if it comes, we'll give you time. But meanwhile, we can have.
Sir, based on our experience and based on the literature, what we found that even though intravitreal therapy can be considered, so most of these lesions very well respond to focal therapy. So intravitreal injections can be considered for lesions which are very close to fovea and where you feel there is a risk of damage to the fovea. In these cases, we might consider multiple injections. Usually they don't respond to a single injections, but we do not have any information on giving multiple injections, but they respond very well to focal laser. Again, after this slide, it's not moving. That's okay. Some problem.
Here's a nice collection of cases, and the literature does suggest like what you have put across. Only thing is, yeah, the indication for anti-VEGF will be the macular edema. Presence of macular edema. That too, we do wait for some time, for say 2 to 4 weeks, and if then it doesn't resolve.
But most studies say that anti-VEGF, it doesn't usually work that well.
Yeah, so in those cases you can top it up with a focal laser.
Focal laser.
Otherwise, many times, so observation is one. If it's not involved in the
macula, if the macular edema is stable and vision is good, observation is also a good option.
Yeah, so